So what we are trying to do is to speak to you in a dialogue. So we try to share experiences, to speak about lessons learned during the second wave. And we are two small hospitals. Paracelsus on the right side is in the Black Forest. The Black Forest is not black, but green, but it's a mountain region in southern Germany. Our hospital is a small hospital with about 65 inpatients and outpatient departments. It's about anthroposophic medicine with the healthcare services you can see here: internal medicine, palliative care, oncology, integrative pain, and the intermediate care unit. And our hospital, which is quite different from the big Berlin Havelhöhe hospital, we have been collaborating with the other hospitals in our county, a very close, a very good, a very friendly and warm collaboration. So, for example, that many patients who came to us were sent from the other hospitals. Sometimes we had to send patients to their ICUs because we do have an intermediate care unit in the hospital, but not an ICU and no facilities like ECMO. And if you want to check about Paracelsus, you find in red our internet address. Sorry, it's just in German, but with Google Translator, everything should be possible. I hand over to Peter.
Yeah, the Klinik Arlesheim is actually an amalgamation of the Ita Wegmann Klinik, which was founded in 1921, and the Lukas Klinik, which was founded in 1963, and we actually only amalgamated in 2014. Our profile is very similar to the Paracelsus Krankenhaus. We've also got the internal medicine, we've got psychiatry and psychosomatic medicine. And I think the similar position in the corona during the second wave was also that we cooperated very closely. In fact, in the county Basel-Land, it was decided that the patients would go to, which is where the Klinik Arlesheim is. It was decided that the patients would go to two hospitals. One is the big county hospital, and the other one is us. And it was decided then that all those patients who don't need an ICU, because we don't have an ICU, would come to us. So we actually got quite a lot of patients from care centers, from old age homes, and all those who didn't want resuscitation or ICU care. Yeah, and I think that the reason why we're presenting this together, because from the beginning we exchanged very closely with Thomas in Unterlengenhardt our ideas and their ideas to get us set up for this thing, which is not an easy thing for a small hospital. You have to set up many processes and many protocols and so on. Yeah.
So what you can see here, looking at these smaller hospitals, is that our primary goal was to give the patients an integrative anthroposophic treatment in order to prevent an ICU stay or in order to prevent ventilation. And so we will see how this worked. So COVID-19, this is something you saw in Friedemann's presentation. We are speaking about the second wave, which was from October, November to February. You can see the weekly ups and downs in the rates in Germany. And this is actually interesting because these are official numbers of the number of patients treated in hospitals. The orange ones are ICU patients with invasive ventilation, and the yellow ones are without invasive ventilation. You can see that in the first wave, most of the patients had to be ventilated. And in the second wave, the number of those who did not need that was much higher. And of course, in the very beginning, during the first wave, when all the anthroposophic hospitals saw their first COVID patients, we understood that there are always two directions, two perspectives to look at the disease. You can look at the virus, and then you speak about vaccination and hygienic prevention of transmission, viral transmission. But the question of the organism, the host, how does a human being react, is so important in COVID. And that's why we thought we should work on an integrative treatment concept, because many features of the course depend mostly on the reaction of the host. There was a treatment concept focusing on these different types of symptomatology. So the asymptomatic patients, the mild flu-like symptoms, which is more upper airway infection, or at least a clinic of upper airway infections. We often see infiltrates in the lung, even with these patients. And then the severe pneumonia and the hyperinflammatory syndromes. And so this is just to go through it very quickly. I will show you where you can read more about that. We developed a consensus from the decades of anthroposophic treatment experiences with viral infections, viral pneumonias, in order to work with that. When we started to look at COVID, and then during the first wave, there were a lot of learnings, and during the second wave, others, and we will speak about that. Where can you find it? Friedemann announced that I would share this again. So there is a webpage, Anthromedics, and there you can access practice, and you can access infectious diseases, and then you go down to COVID-19, and then you find a lot of treatment recommendations for prevention, for medication, for nursing applications, and so on. And this will give you an impression how these concepts were when the first wave was over and we were preparing for the second phase. And this was the starting point for what we did in the hospitals. And as Friedemann showed us from Berlin, and that was our lesson one, we learned that we really need very stable standard treatment protocols. In integrative medicine, we often tend to have very individualized treatments, looking at constitution and all sorts of symptoms and so on. But we learned we have somehow to really focus. Sometimes less is more. And for example, these are tables from Paracelsus Hospital. You see COVID-19 without pneumonia infiltration, with pneumonia. You see then optional medicines that were used, and the individual fine-tuning always is needed afterwards. We even had a clear timetable for the ward. So what you can see here, sorry that it's in German, but I wanted to show the original. You see that nursing applications had that time, that lung external applications had that time, the doctor's visit, music therapy. We did a lot of music therapy for all these patients with a music therapist sitting on the ward, and then the doors to the patient rooms opened just for the therapy, because music therapy may help to treat anxiety, to deepen breathing, to relax the patient. So that was done. You see it here. And so what we really learned is that this structured approach is necessary.
If I can just come in there,
yes,
Thomas,
do so.
Just the previous slide. That's one of the things we copied from you, that in that early exchange of ideas. And I think to appreciate it, one might just reiterate what you already said, that normally we pride ourselves in our very individual treatments. And we did a very similar program with 2 hours slot in the afternoon, where for instance, eurythmy therapists would go, and then there wouldn't be an individual appointment for every patient, but they would go through the ward with obvious advantages as far as efficiency is concerned, and also because the patients were generally very ill. They only needed, well, they could only do sort of 10 minutes of work with each patient. And that was, but then very much appreciated and very effective. So, and then the physiotherapist would go through, and the eurythmy therapist in those 2 hours. That was actually a big Gewinn, something that really helped us.
Yeah. Yes, and I think that was a lesson learned, that there is some sort, how to say, a dialectic of a stable standard care and then the individualized treatment, because we needed that often because of the acute complications with cardiomyopathy, atrial fibrillation, acute heart failure, or encephalopathy with delirium and seizures. And so there was a need to react quickly But we felt that the conventional standard protocol and an anthroposophic standard protocol have been both very, very important. And we had a lot of very individual symptom patterns with long-lasting COVID gastroenteritis or pancreatitis even. And so that was, for us, a big learning. And how was it for you, Peter?
Yeah, exactly. And I think also, well, the slide that we're going to come to now is, where we learned also that the integrative approach with standardized sort of remedies that we could start easily and early on really helped us, because it was often the experience that patients came in a relatively good condition. One would think, well, do they really need hospitalization? And this is, for instance, the example of an X-ray of a 93-year-old man who doesn't have situs inversus, by the way. I don't know why he was operated on at some stage, but I don't think they put the heart back the wrong way. It's just the way it is. But why I wanted to show this is one doesn't see infiltrates, and one sometimes heard crackles, minimal crackles. And if you show the next X-ray, you can see that on a CT scan, which we only did to rule out the pulmonary embolus, there are already considerable infiltrates visible. And this person actually did get quite ill, but 93 years old, and he managed it very well, and actually was one of the people who could go home and didn't need sort of post-hospitalization care, and did very well actually. And there I think we really, with the integrative approach, we really had the feeling we could start early without fearing complications that one might be afraid of, for instance, if you use dexamethasone too early, and that really helped a lot of patients.
Yeah, what we learned in a way was something that our traditional Chinese medicine colleagues from China reported very early in the pandemic, that during the first week of fever, the first week of somehow a localized and not so severe infection, is something like a golden window, an open window for integrative treatment in order to prevent the complications. And we learned here in Paracelsus that every patient who was ill enough to be hospitalized, he would receive the medicines that were originally adjusted on hyperinflammation, for example, because we felt to strengthen the regulatory facilities of the organism, to strengthen the patient, to not to go too deeply into these hyperinflammatory states. That should be started very early. So in a way, patients with mild symptoms often were treated with the treatments focusing on the severe pneumonia and hyperinflammation syndromes. And of course, this is something which has to do with the approach to fever. Friedemann showed this picture as well. We didn't know from each other that we would show that, but it's a very clear and simple graph showing that there are different stages of COVID. And of course, in the early stage, the early infection with the viral response of the organism, here fever is of a high value very often in all sorts of viral infections. But the phase of what fever is and how fever appears may change in stage 2 and 3, because running into these more septic conditions and hyperinflammation, you will find a fever which is not an expression of a healthy organism somehow with a good immunologic response, but it can be an expression of a hyperinflammation syndrome leading to severe organ complications. So for us, it was somehow a learning that in the first phase, we would like to support what we can call a healthy fever. So a helpful activity of the immune system, not to suppress the fever. Patients having this type of fever often have a homogeneous warmth distribution in the body. And to look at warmth organism, warmth regulation is a very central pillar in anthroposophic medicine. But if the fever goes on too long, patients have a disruptive or an exhausting fever. So they have a gray appearance. They may have very cold regions of the body, for example, the back and the kidney region. But in the central part, they will have very high temperatures. They will have a gray appearance instead of rosy appearance. And so one focus for us in order to prevent these later stages was to intensify the early immune fever reaction with medicines as well. So anthroposophic medicines like ferrin, phosphorus somehow enhance the defense of the organism, the immunological activity, and then more to guide the fever in order to support, to strengthen the organism with bitter agents like Ensiana, but not suppress the fever. Peter, could you comment on your experiences?
Maybe go to the next slide. Genau. It was, yeah, so I think to summarize, or my summary would be always to take fever seriously. And this is what I always say to patients, but treat the cause and not the fever on its own. And there were even studies, or there were indications earlier on in the pandemic that ibuprofen would actually negatively influence the outcome. So you already mentioned it, but so some of the substances that we use to guide the good fever rather than to sort of drop it, it would be the yellow Ensian. We used Artemisia a lot, and then silver in higher potencies, Argentum. Lemon wraps are very often used. And then I think it's important always that you need to motivate people, and you need to explain still, even though there's a lot of indications, even in university medicine, that fever is not always bad, because it's not easy for patients, and certainly not for the relatives, or that to be with somebody who is going through a high fever. And it's also a lot more work for the nursing staff compared to just giving a tablet, to do lemon wraps and to wipe a damp forehead and so on. Yeah.
Okay.
Yeah, and then this is now the sort of where I really get warm. The external applications. I think Friedemann Schad already pointed that out. They're a very central element in anthroposophic medicine, not just a nicety or something to make a hospital attractive. It's already long been proved that substances can work without actually being absorbed. Neurohumoral immunological studies have shown this, and the compresses and the wraps that we used most often were ginger. This incredibly enveloping sulfuric warmth. Sometimes if people were very ill, this would be a bit too much. I think Friedemann Schad also pointed this out already. And then we used thyme oil applications, which we very often used in the evening, which has a very clear antispasmodic effect, treating these dry coughs, etc. And if you go to the next slide, you can actually, this is now, Thomas pointed this out to me, this website. If you want to learn how to do these applications, then you can go to this website. Here is an example. We can't show it now, but it's an example of how you do a ginger test compress. The instructions are even in English, so you don't need to run Google with this particular video. Yeah, very, very nice how to do these things. Yeah.
Yes, and for us, it's a long-standing experience that these external applications have the same value, or sometimes a higher value than medicines, natural medicines. And so we are happy that these web pages exist nowadays, because you may live in a country where you don't have access to some sorts of integrative or anthroposophic medicines in the form of drugs, registered drugs, but for the external applications, this is feasible everywhere, and there is a lot of experience, and so we are happy that it's easy to learn because it's shown by video, and it's easy to copy it with the patients. So of course, looking at this integrative approach, we thought that we have to speak about low molecular weight heparin, dexamethasone as well. In the second wave, both So the anticoagulation and the dexamethasone saved about 20% of lives, less mortality. And for us, we used it, the low molecular heparin, in every patient, in high-risk patients. We used it in higher dosages, often in combination with some anthroposophic medication, the Kalium aceticum combo, Stibium. And for the hyperinflammation, we learned that it's somehow an art to handle dexamethasone appropriately, because if you give it too early, you may have a strong immunosuppressive effect. And there were some patients where we felt we should have been waited, and there were other patients where we felt we should have started earlier. So for me, for example, in my practice, I learned that looking at the patient when they leave this phase of the so-called healthy fever, if they start with dizziness, gray appearance, with the first signs of shortness of breath, then it may be good to start with dexamethasone early enough. I think what you learned in Arlesheim, Peter, is something similar.
Yeah, we had a very I think that we kind of, it was a search to find out when to start the dexamethasone if one needed it in the end, and we also found that one could start it too early, and then we had one experience where we felt, well, that we could have avoided that patient eventually died. I don't know if that would have been just because of that. But what was very helpful, for instance, is with these sort of late onset, with these the joint pains and yeah, the autoimmune inflammatory, or the inflammatory, late inflammatory phase. Yeah. Yeah, and this was also pointed out by Friedemann Schad. I think it was certainly in Switzerland, there was a big action in the old age homes to get people to decide what they would want in case they got COVID, and then they were sort of encouraged more or less to kind of say, well, I don't want to be ventilated and so on. So by the time that the wave really got hit, sort of thing, people were convinced that if they got COVID, that they were going to die. And then very often the relatives actually wanted them to come to us, so that if they died, they would die in our hospital. And then they would be brought by the ambulance personnel, who were also wrapped up completely unrecognizable. And so there was an immense amount of anxiety and fear. And we discovered that it's very, very important to sit down on a bed and take a hand, even if you have to glove that hand, and try to avoid the physical barriers getting between you and the patient, sort of thing. And another big thing which with the other hospitals strictly forbade is that we made visits possible, 1 hour per patient per day, which sounds quite restrictive, but it's a lot of work for the nursing staff to instruct the relatives on how to get dressed and so on. And that made a huge, big difference. In fact, one patient who came from an old age home and who did very well, at some point said to her daughter she would have actually preferred to have passed away in our clinic rather than have to go back to the old age home and be locked up again, so to say, be isolated, because of the infectious things. Many of the old age homes were completely isolated from, relatives weren't allowed to visit. So we think that made a big difference, and it's very important to focus on that aspect. Yeah.
Yes, and we learned, in Germany, it was somehow accepted that if somebody would die in a very palliative situation, that then the relatives should be able to visit in order to not die alone. But we learned that in crucial situation, when the question was, is there a will to live, to continue, then the contact was needed as well. So for example, I remember an old lady with severe Parkinson's disease. She was nursed by her husband for a long time. Then the husband came to another hospital on the ICU with COVID. He died there. She was not able to say goodbye to him. She was not able to see her daughters. And then we felt she deteriorated. She got worse. And then we felt that there is a moment when we allowed the two daughters to come and sit there for 3 hours to be with her. And that was a turning point, yeah, to allow, to reconnect with the life, to reconnect with the loved ones, to reconnect with what makes life meaningful. And this is about relations, of course. So we think that how the title was done, we should isolate the infection, but not the infected individuality. So looking at the outcomes, Peter, do you want to start?
Yeah, it's basically we sort to show this. I basically to show this that it's that the sort of the post-COVID morbidity is very high. As I mean, 18% or 18 of the 120 patients that we had up to the point of making this graph had died, which is quite a lot considering, but then again, considering that we got all the patients that didn't want to be ventilated and so on, it's actually quite, we were quite pleased that it was so little, so to say. But we see here that a lot had to go to a rehabilitation center. And many were newly admitted then to an old age home afterwards, who had been independent up to that point, but then couldn't be independent anymore. And those 50 who went home, many of them needed home nursing care for quite a long time. So yeah, and so you can see that the profile of each hospital depends on the cooperation regionally and if you have an ICU or not and so on. Yeah.
So in our patients on the right-hand side, first of all, it seems to be quite good, but that was due to our selection of patients as well. So because patients who were transferred to us from the other hospitals were those who were in a palliative situation or who were judged not to be at risk to get ventilated mechanically on the ICU. So there was some sort of positive selection. Nevertheless, you can see there were patients we had to transfer to the ICU, to another hospital. Half of them died, half of them survived. But in any case, our overall impression was that looking at the general numbers and our numbers, we often saw with the patients good causes. We were optimistic to do something good. This is no proof of being better than others or something like that. But when you see that of these total numbers, you have so many people with all the complications I showed you, who finally survived at this big age, we feel that this is extremely encouraging to go on with anthroposophic and integrative treatments, not only focusing on the virus, but on the person and on the healthy organism, the healthy resources as well. And I think because we are late in time, you can look at these take-home messages. We won't go through it again because we are a little late. Thank you very much for your attention. Thank you, Peter, for this wonderful collaboration to develop slides that we share and to do this in a dialogue here.
Yeah, thank you everybody as well.